Welcome to the May 2024 LACNETS educational event. I'm Kavya Velagapudi, Executive Director of LACNETS.
I'm Lisa Yen, Director of Programs and Outreach for LACNETS.
And I'm Heather Davis, the Associate Director of Advocacy and Outreach at LACNETS.
Today's presentation is on high-grade neuroendocrine neoplasms and small cell lung cancer. A special thank you to our supporters Ipsen, Crinetics, and Curium. LACNETS stands for Learn, Advocate, Connect Neuroendocrine Tumor Society. Our name also states the mission of our patient advocacy organization. The LACNETS staff includes Lisa Yen and Heather Davis. The board includes Donna Gavin, who is the sister of LACNETS founder Giovanna Joy Sambesi, and NET patient Mary Dunleavy, who has been living and thriving with NET for 19 years. We're excited to share that LACNETS is partnering with the Carcinoid Cancer Foundation, or CCF, to provide support line assistance and other programs. For more information, visit lacnets.org/supportline. Now over to you, Heather.
Thank you, Kavya. After Dr. Chauhan's presentation, he will take general questions on high-grade neuroendocrine neoplasms and small cell lung cancer. Please note he cannot provide personal medical direction on your specific diagnosis. To submit your questions, go to the May Educational Events page at lacnets.org/May 2024. Again, to submit your questions for the live Q&A, go to LACNETS, LACNets.org/MAY 2024. Now, before we get started, here are some tech tips for ideal audio and visual quality. For audio, ensure your volume is unmuted on the webinar broadcast screen. Locate the volume control on your device and increase or reduce the volume as needed. YouTube Live offers a closed captioning feature as well. For the video, you may enlarge the webinar broadcast screen by clicking the Expand Screen button located in the bottom right corner. This webinar is being recorded and can be viewed on the LACNETS YouTube channel and video library shortly after this broadcast. Our YouTube channel features over 300 videos and podcasts. Use our playlist to find patient stories, information on PRRT, liver-directed therapies, clinical trials, nutrition, imaging, PhenoPara, and our annual conferences. And you can also find our videos by topic in our video library on the homepage as well. Follow LACNETS on social media. We are on Facebook, X, and Instagram with the handle @LACNETS. And be sure to add us to your Safe Sender email list. I'd like to remind our audience that LACNETS webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this webinar are the experts' personal opinions. Please contact your medical team with questions or concerns about your individual care or treatment. And now I'll hand it back over to Lisa.
Thank you, Heather. Register now for our 2024 Neuroendocrine Tumor Patient Conference that will take place on Saturday, June 15th. Our virtual annual conference is our biggest event of the year. This year's theme is Deepening Your Understanding of NETs. Hear from over 13 neuroendocrine tumor experts from across North America and also several NET patients and caregivers from the comfort of your own home. Register on our website, lacnets.org/2024 conference. You won't want to miss this. One of the challenges we often hear from patients and caregivers is finding information about specific clinical trials, in particular, information that is easy to understand. As the wife and caregiver of someone living with metastatic neuroendocrine cancer, that is also important to me. We want to stay informed and engaged with clinical trials as we explore possible treatment options. And this is why LACNETS created a clinical trials guide. It's an easy-to-use educational resource that features several key clinical trials for neuroendocrine cancers. You can browse the site by the type of neuroendocrine cancer, such as high-grade neuroendocrine carcinoma. You can also browse by some of the types of treatments, such as PRRT. You will find brief patient-friendly videos and information about each trial. We hope our clinical trial guide will help you better understand clinical trials for neuroendocrine cancer. I'm pleased to now introduce today's speaker, Dr. Aman Chauhan, a medical oncologist and neuroendocrine cancer expert who leads the University of Miami Neuroendocrine Cancer Program, and he co-leads the Sylvester Theragnostics Drug Development Program. Prior to moving to Miami, Dr. Chauhan was at the University of Kentucky's Markey Cancer Center in Lexington, Kentucky. Dr. Chauhan earned his medical degree in India, and then he went for a dual residency in both internal medicine and pediatrics at Louisiana State University in New Orleans. Dr. Chauhan completed his fellowship in hematology and oncology at the University of Kentucky, especially focusing on neuroendocrine tumors. Dr. Chauhan also completed a special physician externship at the National Cancer Institute that focused on designing clinical trials and clinical research projects. He has been active in both the clinical care of neuroendocrine cancer patients and in research. And in fact, he only sees neuroendocrine cancer in his clinical practice. And he is known and respected as a specialist in high-grade neuroendocrine carcinomas and small and large cell neuroendocrine carcinoma in particular. On the research front, Dr. Chauhan is a principal investigator on several neuroendocrine cancer clinical trials. He's authored over 70 scientific publications and book chapters, and he's received a Career Development Award from the NCI as well. Dr. Chauhan is an active member of LACNETS, which is the Medical Professional Society for Neuroendocrine Tumor, and he is a member of the Communications Committee. He also serves on the ASCO and AJCC NET Guidelines Committee, and you may have seen the recent AJCC NET Guidelines that was just released last week. Many of you already know Dr. Chauhan is someone who's passionate about helping patients. Perhaps you've seen him speak at a patient conference, or maybe you've attended one of the high-grade support groups that's led by Susan Meckler-Plummer that Dr. Chauhan joins regularly. We have all witnessed Dr. Chauhan's tireless and inspiring efforts on behalf of the neuroendocrine cancer community, and we're really excited to have him join us today to talk about a topic near and dear to his heart. He gave a presentation about 2 years ago, and today he's returning for an update on high-grade neuroendocrine neoplasms and small cell lung cancer. Welcome, Dr. Chauhan.
Hello, everybody. Welcome from Miami. My name is Aman Chauhan. I'm a medical oncologist. I lead our Neuroendocrine Cancer Program at the University of Miami, and I co-direct our Theragnostics Program at Sylvester Comprehensive Cancer Center in Miami. Today, we will be talking about a very unique subset of neuroendocrine cancers called high-grade neuroendocrine carcinomas, and specifically also talk about small cell lung cancers, because they are very similar, or may consider them sister cancers. You probably already know neuroendocrine cancer is not a single disease. It's actually a spectrum of disease. Neuroendocrine cancers can be either bucketed into two large groups, neuroendocrine tumors or neuroendocrine carcinomas, NET or NEC. So that last letter, the tumor versus carcinoma, is absolutely critical in understanding the disease, the course of disease, and how we manage it. The terminology to describe the spectrum of disease sometimes could be confusing, but we are all talking the same language in different words. When we are dealing with gastrointestinal or extrathoracic outside lung, could be gallbladder, pancreas, ovaries, we usually call them either well-differentiated neuroendocrine tumors, and there are 3 varieties of it: grade 1, grade 2, grade 3, and then the poorly differentiated neuroendocrine carcinomas on the more aggressive end of spectrum. If you look into the middle row, for the lung neuroendocrine cancers, we usually classify them as a typical carcinoid, atypical carcinoid, and then high-grade poorly differentiated neuroendocrine cancers, which there are further 2 subtypes, the small cell lung cancer and large cell neuroendocrine cancer, LCNEC. I've put them side by side because they essentially are very synonymous the typical carcinoid with the well-differentiated grade 1, grade 2, the atypical with the moderately differentiated or grade 3, and then poorly differentiated neuroendocrine carcinoma of our GI world or extrathoracic world are basically small cell lung cancer and large cell neuroendocrine cancer of the lung world. So that's very important for us to understand the basic terminology so that when you're communicating with your medical team, you know exactly what disease we are dealing with. To simplify and consolidate this very important concept, you can see the two buckets, neuroendocrine tumors and neuroendocrine carcinomas. Neuroendocrine tumors can be further grade 1, grade 2, grade 3 based on Ki67 or mitotic index. Neuroendocrine carcinomas, by definition, are always grade 3. So for today's discussion, we will focus on neuroendocrine carcinoma. LACNETS have done an incredible job in summarizing neuroendocrine tumors, and there's a plethora of literature and material on their website regarding neuroendocrine tumors, diagnosis, treatments, clinical trials. For today's talk, we will focus on this more rarer but more aggressive subset of neuroendocrine cancers called neuroendocrine carcinoma, which there are further of two types, small cell and large cell. Let's learn a little bit about the burden of disease first. Before moving to Miami, I was practicing in Kentucky. Now, these high-grade neuroendocrine cancers, or NECs, can originate anywhere in the body, but by far the commonest location is lung. In lung, the small cell plus large cell neuroendocrine cancers comprise about 12 to 14% of all lung cancer nationally. But there are certain hot spots. For example, Kentucky is one of those. So if you can see in rural and Appalachia and even non-Appalachian Kentucky, this incidence is about 17 to 18% of all lung cancers. I'm noticing something similar in our area in South Florida as well. So smoking prevalence goes hand in hand with small cell lung cancer incidence. What is very problematic about these small cell lung cancers and sister cancers called neuroendocrine carcinomas or poorly differentiated neuroendocrine carcinoma is the aggressive nature of these cancers. Look at these survival rates. It's very sobering, to say the least. The bottom line that we see, those signify the survival rates in terms of percentages as the time passes. The 5-year survival rate for our disease for NECs, be it small cell or extrathoracic high-grade neuroendocrine cancer large cell, is in the range of 10% or less. Let's review how do we go about managing these high-grade neuroendocrine cancers. Unfortunately, most of our NEC patients at the time of diagnosis are dealing with metastatic or advanced disease. So for today's talk, I will skip on the early stage cancer, because if we get lucky to catch these very aggressive cancer in earlier stages, the treatment might change and we might use surgery or radiation in addition to chemotherapy. But for today's talk, we will focus on metastatic disease. And that's how, unfortunately, most of our patients present with, because by the time they see the doctor, the cancer is already spread. So first thing I would like to really emphasize with the diagnosis of NEC is sense of urgency. You don't want to take days or weeks to see an oncologist and start treatment. There is an absolute sense of urgency because these are rapidly growing tumors. The doubling time for some of the small cell can be as small as 2 weeks. So there is no time to waste. The usual treatment back in the days in 1970s used to be a very toxic cocktail of chemotherapy like cyclophosphamide, adriamycin, vincristine. Fortunately, in 1980s, we learned a drug you probably have heard of, the platinum doublet, the carboplatin etoposide, cisplatin etoposide, to be equally effective but much better tolerated. So since 1980s, this has been our standard of care treatment for the frontline management for metastatic high-grade neuroendocrine cancer in most instances, especially the thoracic malignancies. In the GI world, there might be some differences, and some providers might also use FOLFOX, FOLFIRINOX, and then we'll get to some of those nuances in a bit. For almost 4 decades, we were stuck with the platinum doublet because it works. If I give platinum-based chemotherapy to 10 of my high-grade neuroendocrine cancer patients, 8 of them will respond. However, the response is short-lived. Most of the time we will see that the cancer will show evidence of progression by 4th month, if not by 6th month, or definitely by 8th month in most of the patients. So although this frontline chemo with platinum works really well, the response is not sustained. We eventually made a breakthrough a few years back when we learned that when you add immunotherapy to the frontline chemotherapy in small cell lung cancer, we can enhance the benefit, and we were able to show that the patients live longer. However, the degree of benefit is modest. So patients who got just chemotherapy versus chemoimmunotherapy, the median overall survival was 10 months versus 12 months. So it might seem that, oh, we only made 2 months of a difference, but this was statistically significant, and for individual patient, those are median. That might mean several months for certain patients. So we were very happy, and this was a very welcome addition to our frontline management, where we add a relatively well-tolerated immunotherapy drug when added to frontline chemotherapy. We now have not one, but a couple of options. So in frontline setting, we add atezolizumab. In the second study, studied durvalumab, very similar results, about 2-month benefit in addition of or overall survival when added to frontline chemotherapy. So again, it wasn't one-off or a fluke. The drugs work, and we've shown in a couple of different randomized phase 3 clinical trials that by adding immunotherapy to chemotherapy can certainly benefit certain patients live longer. Now, unfortunately, despite robust responses to the frontline chemotherapy and immunotherapy in small cell lung cancer, most of the patients would eventually relapse. In roughly about 5 to 6 months into the therapy, we will see the cancer started progressing. And we have to then switch gears and jump onto the second line therapy. Second line treatments and onwards, unfortunately, don't respond very well, and traditional success rate is 10% or less. Having said that, I have seen quite often the patient's second and third line can still have durable responses and can have disease stability for 6 months, a year, sometimes even 2 years. So by no means that patient should not be given a challenge with second and third line therapies, as long as the organ function and performance status, that means fitness level, allows us. I always encourage our patients to try second, third, and fourth line treatments. One of the key treatments that we often use in small cell lung cancer world for second line therapy, and is now FDA approved, is a new chemotherapy called lurbinectedin. And in a smaller-ish study, it was shown that this is quite effective as compared to traditional chemotherapies, where the response rate was in 10% range. Almost 35% patients responded in this smaller study. It is a little bit tough on your bone marrow, so take good care of your bone marrow. Patients can have cytopenias, low white blood count, low platelet counts, but with proper precautions, medications used to help to recover stem cells and cell counts like Neulasta. We can certainly shepherd a lot of patients on these treatments without any considerable harm. Now, subsequent therapies for small cell lung cancer, and there's a list from the current NCCN guidelines. There's a slew of treatments. So it's not that we don't have treatments. Unfortunately, the success rate with every subsequent line of therapy dwindles, and that's where the challenge of treating high-grade neuroendocrine cancers like small cell lung cancer lies in. Having said that, I routinely see patients who've been told that there is no more treatment option for you after 1 or 2 lines of therapy, and they're asked to either consider hospice. And although it might not be a bad approach to engage palliative care early, but certainly there are good treatment options in patients who have strong performance status and have good organ functions. And I encourage them to try different treatment because all of these treatments I have seen anecdotally durable responses. So there's no way to predict which patient will respond and which patient do not. Now let's switch gears a little bit. We talked a little bit about small cell lung cancer. For this particular talk, our audience are coming from all spheres of high-grade neuroendocrine cancer. Some of you probably are dealing with or knows friends or family with extrathoracic high-grade neuroendocrine cancers like pancreatic high-grade, gallbladder high-grade, colon high-grade, rectal high-grade neuroendocrine cancers, ovarian high-grade neuroendocrine cancers. They unfortunately behave very similar to small cell lung cancer. So a lot of our treatment strategies are extrapolated from small cell lung cancer. So the frontline treatment is still quite often platinum doublet, carboplatin and cisplatin etoposide combinations. But for GI high grades, we can also use FOLFIRI or FOLFOX as frontline regimen. It's really treating physician's choice. In my practice, I often use FOLFIRI, FOLFOX as second line treatment. And again, there is no way for us to predict which treatment is better. There's no head-to-head comparison in at least larger, stronger studies. So there are both are good options to be considered at some point in time in treatment sequencing. Now, I'm also a big advocate of doing next generation sequencing or genetic testing in high-grade, poorly differentiated neuroendocrine cancers, because up to 7 to 10% of times we can find a mutation for which we have a target and a drug. For example, if we see the patient has intermediate or high tumor mutation burden, we can give Keytruda, which is FDA approved for that indication. If we come across BRAF mutation, we can try BRAF inhibitor. There is another very rare mutation called NTRK mutation, but if we find that, there's a game changer drug with larotrectinib and trectinib. So I'm a big advocate of testing for potential somatic targetable mutations. It's a shot in the dark, but if we don't check it, we will not find it. So that was the current landscape of how we manage this very aggressive, rare disease with very limited effective treatment options. But all is not lost. I think there is a lot of optimism in future, and I think the clinical trial holds the key how we will one day get a really tangible breakthrough and hopefully even cure some of the patients, if not all. One of the first trial that I'd like to highlight in today's talk and looks most promising is testing a drug or a class of drug called BiTE antibodies. So let's learn a little bit about BiTE antibodies. This is a study by BI. There's another product by Amgen, and there will be, I'm sure, several more coming down the pike. But let's learn a little bit about what is BiTE. BiTE antibodies, it stands for bispecific T cell engagers. So bi, as you can imagine, stands for two. So it has two arms, as you can see on your screen. And one of the arm attaches to DLL3, which is heavily expressed in high-grade neuroendocrine cancers like small cell and large cell neuroendocrine cancers, regardless of where they are, lung, outside lung. And the other arm of this bispecific T cell engager attaches to T cell, as the name says, T cell engager. It engages the T cells. So what it does when we inject this drug into patient's body, one arm is attaching to the DLL3 on the tumor cells, the pink, and the other arm attaches and catches the T cells and brings them closer to the cancer cells. So it's really making your own body's immune system, your own T cells, work hard and fight the cancer cells. So it's a type of an immunotherapy drug. And that's the beauty of it. It's not a toxic chemotherapy. It's an immunotherapy drug which making your own body's immune system fight against cancer cell. So what do we know about the clinical effectiveness or efficacy data from this drug? Again, I'm showing you some of the data presented last year at ASCO from early phase studies using these BiTE DLL3s. And as you can see, this is a waterfall plot. All the lines or the bars which are hanging upside down that signifies the tumor shrinkage. The deeper the bar goes, the more the tumor shrinkage. So you can see here almost half of the patients who received this drug had tumor shrinkage of some degree. That's just incredible as compared to just a few minutes back I highlighted that the traditional treatments in second, third, fourth line, the response rates are in category of 10% or less. When you see 30 to 40% patients are benefiting, either achieving stability in the progressive cancer or shrinkage, that is profoundly gratifying and really excites us in the field. We, by the way, saw very similar results for the other product in the Amgen. The name of the drug is called Tarlatamab. These are early phase study and it's available in public domain, these data, so you can review it for yourself. In this graph, what I'm trying to showcase is the durability of response. Now, we like chemotherapy because it works fast and it's effective, but one of the key issues with chemotherapy-based regimens are the durability of response, that even if it helps the patient, the response does not last long. It is a matter of time that the cancer starts growing again, develops resistance to the chemotherapy. What we are noticing in the early phase studies that patients who do benefit from these BiTE antibodies tend to benefit for a long period of time. The bars here with the arrow shows that this patient continues to be on the treatment at the time this data was presented. So some of them are already going a year and a half, and others are hitting a year mark, and some are in 8 or 9 month mark, which is extremely gratifying statistics to see. Very crucial aspect of any new drug whenever we are doing early phase drug development is how safe is this medicine. Might be effective, but what if it is extremely toxic? So in this slide, I'm showcasing some of the early side effect data. And as you can see, although majority of patients had some degree of side effect, but if you look into the details, most of the side effects actually are low grade or grade 1, grade 2 CRS syndrome, which I have treated a lot of these patients in early phase trials, which really means fever or chills. So patient, when we are infusing this drug, almost all of them or majority of them would have some degree of fever or chills. And that is because your T cells or immune system is being engaged and you're seeing an inflammatory response. So fortunately, the higher grade reactions or grade 3, grade 4 side effects were extremely low, and very few patients had to stop the treatment for significant side effects. So all in all, at least for now, the drug seems to be very well tolerated and is moving forward in drug development with various companies investigating in larger studies. So we will see this year, hopefully a little bit more of data, some of these matured studies. So in conclusion, for this BiTE antibodies, very promising, provocative data, not only from one study, but across the board, whosoever is developing the DLL3 specific BiTE antibodies. You can see it helps not just small cell lung cancer, but in fact, poorly differentiated neuroendocrine carcinomas outside lungs also benefit, and large cell neuroendocrine carcinomas also benefit. So these data are very, very exciting. And the best part of the DLT BiTE story is that these responses are durable. So these are sustained results. All right, now let's switch gears. So besides DLL3 BiTE antibody, there are also some other excitement in our field with novel combination and targeted therapies. This study, which was recently presented from China, tested two drugs. One is your immune checkpoint inhibitor. Those are the kind of drugs that you've heard of, like Keytruda, Opdivo, Nivolumab, those class of drugs called immune checkpoint inhibitors. And they combined it with a VEGF tyrosine kinase inhibitor called enolintinib. When they combined this with the standard of care chemotherapy, they were able to show a significant improvement in overall survival in small cell lung cancer frontline. And you can see the patients who got these treatment combination lived for median survival 19 months as compared to 11.9 months. That's extremely impressive. However, just a word of caution, previously studies done in East have not had very parallel result in West. So I would highly encourage our field to look into these combination and do validating study here in the Western population. There was also long-term follow-up data from immunotherapy. If you remember, we talked about how adding frontline immunotherapy to chemotherapy showed a little bit, but definite benefit in overall survival. We now have data from a long-term follow-up from these studies, and we were able to see that patients who benefit from immunotherapy tend to benefit long-term. You see the blue curve. These are the patients who got immunotherapy in addition to chemotherapy, and there is this tail end of the curve. That means there were about 12% patients still alive at 5-year mark. This number was 7% just a few years back, before the era of immunotherapy. So although just 12% patients still survive 5 years and longer for small cell lung cancer, this is almost double the number for the survival just for a few years back. So we are making progress, and hopefully with newer agents we'll make even better progress. High-grade neuroendocrine cancer is a passion of mine, both in my clinic and my research. We ourselves invested in an investigator-initiated study focusing on small cell lung cancer and tested immunotherapy with nivolumab and a PARP inhibitor, a pill called rucaparib, as a maintenance strategy after frontline chemotherapy. And we presented this data last year in a big conference called AACR. What we were able to show is that 90% of our patients were alive at 1 year from diagnosis and about 54% at 2 years from the start of platinum doublet, which is extremely interesting data. And I hope that these concepts can move forward into larger randomized studies so we can really confirm these early pilot findings. My good friend Dr. Kareem actually did a very similar study, a much larger national federally funded study where they tested a different type of PARP inhibitor with standard of care atazolizumab, and they selected these patients for SLFN11 mutations. And as you can see, the difference is rather narrow, but it is definitely there. So patients who got the combination, the median PFS 4.2 months as compared to 2.8 months. There is something to the combination, and I look forward to the long-term follow-up data from these studies. Last but not the least, you've heard about PRRT and Theragnostics, very profound medication currently in use for our well-differentiated neuroendocrine tumor patients. But is there a role for these in high-grade neuroendocrine carcinomas? And one of the studies we did when I was in Kentucky, we tested some of these high-grade neuroendocrine cancer tissues for somatostatin receptors, and actually we found almost 60% of these high-grade neuroendocrine carcinomas, including small cell lung cancers, express some degree of somatostatin receptors. And 30% patients actually express very high somatostatin receptor expression. Those 30% might be a good candidate for targeting SSTR with help of PRRT drugs. And what do we know about that so far? These are the data that I just described. Some of the investigators in our field actually tested that hypothesis. And this is a small cell lung cancer patient, as you can see, with somatostatin receptor positive disease in the chest, those black spots that you can notice. And patient got Lutathera to target those somatostatin receptor positive disease. And after 4 cycles, almost clear, complete response. Those tumors are gone. Of course, these are very small studies to look into the safety and feasibility of these concepts that can it be done. What we don't know is how long would be able to keep the patient in remission, how many patients will benefit from it. Is it truly 30% or is it more or less? But there are exciting studies, and we ourselves at University of Miami will be opening various PRRT studies looking into these high-grade neuroendocrine cancer patients. I would like to finish our talk with one of the studies that we are developing at Sylvester Comprehensive Cancer Center at University of Miami for our high-grade neuroendocrine cancer patients, regardless of the site of origin, lung, extrathoracic. And revolves around a very novel concept of adding an oncolytic virus is a bioengineered immunotherapy that targets high-grade neuroendocrine cancers, and we are adding it to standard of care immunotherapy combination, the ipilimumab nivolumab combination. These are some of the animal data that we presented at NANETS a couple of years back, and as you can see, the mice after treatment, these tumors that you can see on the mice completely disappeared. And more importantly, these were sustained responses. 83% cure rate in the mice. Of course, a lot of things sometimes looks very promising in mice. The next step is to confirm these benefits in actual patients. And we've been working very tirelessly in bringing this to reality. So hopefully sometime this year, we will treat our first in-human patient with these combinations. So stay tuned. I like to summarize by saying that unfortunately, very aggressive cancer, very important to have sense of urgency and not delay care. Don't worry about seeing a specialist. You have to start the treatment first and then see the specialist, because there is more ground to be lost if you don't start the treatment right away. Frontline treatments very effective with use of chemotherapy. For small cell lung cancer, we also add immunotherapy. There are very promising second line clinical trial options, especially DLL3 BiTE seems the most promising of the lot, but there are other treatments, including radiopharmaceuticals, and that might be of potential interest, especially because these are very radiosensitive tumors. With that, I would like to say thank you to LACNETS for giving me this opportunity. We at University of Miami have a comprehensive high neuroendocrine cancer program which caters to both low-grade and high-grade neuroendocrine cancer from all sites, from head to toe. And thank you so much, LACNETS, for they've been unwavering support of our program for years, so that we can hopefully continue to focus on our research and education efforts for this rare disease, and bring some sort of change in outcomes for our patients. Thank you again for the opportunity.
Thank you, Dr. Chauhan, for joining us today. And thank you also for the recent tour of your Sylvester Comprehensive Cancer Center. And it's really amazing what you're building there. You've been there just over a year, and it's phenomenal, the trials that you've brought there and the work being done. And we're really excited to see what you'll continue to do there as well.
Thank you, Lisa. Thank you so much. Yeah, it's been an exciting 1 year in Miami, a huge patient population that we cater to, roughly about 6 million population that is in our catchment area. And it was a critical unmet need, especially for high-grade neuroendocrine cancers, which is often overlooked from various sectors, including industry and government. But that is rapidly changing as I summarize some of these exciting trials that hopefully will lead us to break through one of these days.
Yes, thank you for being that force in change. It's really quite remarkable. 2 years ago, we talked, almost exactly 2 years ago, and it's amazing the work that's being done over the last 2 years in this very much unmet need area. So we're really grateful to you for this very informative presentation. What a fantastic overview on high-grade neuroendocrine carcinoma and small cell lung cancer. We're really grateful that you're able to answer questions from our audience now. And for our audience, just a reminder, this question and answer session is for educational purposes only. It does not substitute for medical advice. Please talk to your medical team with questions or concerns about individual care or treatment. Do not take this as medical advice in any way. And today's topic is high-grade neuroendocrine carcinoma and small cell lung cancer. So there are over 30 questions. We will try to get to as many general questions as possible on high-grade neuroendocrine carcinoma and small cell lung cancer, but we may not cover all the questions. If there are any questions that seem a little specific, we're going to generalize them and kind of talk about them generally. We do not address questions in the order they were submitted, but instead we'll talk about them in an order that makes sense. And please remember, we are addressing general questions only, and Dr. Chauhan will be answering the questions generally. He cannot provide specific feedback on your specific situation. That really deserves your individual care from a multidisciplinary team. So let's get started with the first question, Dr. Chauhan. This is an excellent question. And I've seen this, and other people may have seen this as well. Can you comment on a pathology report that notes both neuroendocrine carcinoma and also a low Ki-67, say 2%?
Yes, a great question. So right off the bat, I would like to emphasize that neuroendocrine cancers, just like we mentioned, it's a spectrum of disease, and some patients have low-grade or well-differentiated neuroendocrine tumors. Others might have high-grade neuroendocrine carcinomas or poorly differentiated neuroendocrine carcinomas. To make matters worse, there is also an extremely rare entity called mixed neuroendocrine, non-neuroendocrine, or sometimes you can rarely have a well-differentiated with a high-grade poorly differentiated neuroendocrine carcinoma. But the key thing to note here is, because these are rare and challenging cancers to diagnose, I always advise for a second opinion, a bath review at a high volume centers, so that we are not making an error, because a lot of time this is usually an issue with either sampling and or incorrect diagnosis. So getting the pathology reviewed at a higher volume center where the pathologist has a very astute eye for these rarer neuroendocrine cancers, that would be my first step. But yes, it can happen. I've seen cases in lung and outside lung as well, where we do find cells belonging to each of these categories, the low-grade tumors as well as high-grade neuroendocrine cancers. And whenever that happens, usually we train our guns at the higher grade neuroendocrine cancers, because that will dictate the prognosis, because that's the bad actor, that's the more aggressive biology, and that's the clone of cell that is going to probably replicate fast, metastasize earlier as compared to the lower grade neuroendocrine tumor. So we first make the management plan based on the higher grade or aggressive biology tumor.
Thank you for that. And this is actually two questions. Two different people asked something similar. So what's the chances of a low-grade neuroendocrine tumor turning into a high-grade? And I think in particular, a frequency of a grade 2, perhaps, NET becoming a high-grade, perhaps all the way to a neuroendocrine carcinoma.
Yes, it does happen. It is fortunately very rare. And unfortunately, we are recognizing it more and more. Maybe 5 or 7 years back, we rarely used to see these transformations from a well-differentiated neuroendocrine tumor to poorly differentiated neuroendocrine carcinomas. It's not uncommon to see a well-differentiated grade 1 turning into a grade 2 or grade 2 turning to grade 3. But to change the morphology from neuroendocrine tumor to poorly differentiated neuroendocrine carcinoma was not very common. However, in the recent years, we have seen cases that have clearly transformed, where we have biopsy proven original diagnosis and the recent diagnosis. Why that happens, we are not very certain at this point in time. Clearly, our patients are living longer. We are trying different treatments, which we didn't have access to maybe a decade back. A lot of patients are getting chemotherapies like CAPTEM, PRRT for the well-differentiated neuroendocrine tumors. So is it possible that we are selecting clones of cells that are very aggressive or acquired mutations that make them de-differentiate and become very aggressive, poorly differentiated carcinomas. So we have yet to understand what changes, why this switch happens. This is definitely not a rule, it's an exception. It is very rare, but we certainly are noticing that this transformation can happen. So always have your radars up. So anytime you have a well-differentiated neuroendocrine tumor case, and it's usually follows a particular trajectory of tumor growth, and all of a sudden one spot in the liver or a certain area or metastatic site has a rapid growth, that should really flag that has there been a change in the behavior or biology of disease. I usually, in that instance, do FDG PET, and if it lights up very bright, the best way to know what's what is doing a biopsy, and that would confirm, are we still dealing with a well-differentiated neuroendocrine tumor, or has it transformed into a poorly differentiated neuroendocrine carcinoma?
Yeah, thank you for that. And so I've heard people wonder or express some concern that perhaps certain treatments like PRT is causing the tumors to grow faster or to transform. What are your thoughts around this?
I don't think so. That's true. You know, what really happens is, and as our patients live longer because of effective treatments that we have introduced, the cancer is also trying to fight off, right? It's trying to develop resistant mechanisms, and we are at the end of the day, the survivor clones becomes very resistant and aggressive, and this is true for all cancers. It's easy to treat a disease for first and second line therapies as compared to fifth and sixth line therapies, because the type of disease we are dealing in a refractory setting several lines down the road, these are very toughened cancers, cells, survivor cells. They have developed acquired mutations which renders them resistant to several of these cytotoxic or anti-tumor therapies. I don't think any particular therapy is responsible to it. These therapies work wonderfully well, but these are not curative treatments. So there will be always some survivor cancer cells that will survive because they had those resistant mechanisms in place that allowed them to survive, for example, PRRT or targeted therapies or chemotherapies. So I don't think, or at least there's no convincing data that any particular treatment per se makes, these tumors become more aggressive down the road.
Thank you. It's like survival of the fittest, perhaps.
Correct.
And so you were talking about treating, the treatment of cancers. What would your first line of defense in a neuroendocrine carcinoma treatment? Would it be radiation targeted therapy or chemotherapy? And also, you were talking about mixed cancers and going with a higher grade. Would this also be similar if you had like a mixed neuroendocrine tumor and neuroendocrine carcinoma?
Carcinoma. Okay, great question. Let's unpack it a little bit. So initial treatment depends on the stage of the cancer. That's a very important pivotal step in the management. So once we know, okay, we are dealing with a high-grade neuroendocrine carcinoma, then we like to stage the cancer, and we use our scans, FDG PET or CT scans, to understand, is the tumor or cancer only in one organ, or it has spread to various organs or different lymph nodes. So broadly speaking, there'll be stage 1, 2, 3, and 4, where 4 means clearly metastatic disease. So for early stage cancer, if we are lucky enough to catch and diagnose a patient when it was relatively either within the primary organ or locoregional in the nearby lymph node, but hasn't really spread to distant organs, we treat it a little bit differently. We try to take a shot at a potential curative intention of treatment. So in addition to chemotherapy, sometimes we employ radiation. And based on the fitness status of the patient, we can do concurrent chemoradiation where we add radiation chemotherapy together. But if we are managing a frail patient, which we feel that not be able to tolerate chemotherapy and radiation together, then sometimes we sequence them. We start with chemotherapy and then consolidate with radiation. Very rarely we find tumors in stage 1. We're very, very early, and sometimes there is a window of opportunity to do surgery. And once the surgery is done, we then follow through with adjuvant chemotherapy, where we give additional rounds of chemotherapy after the surgery once patient has recovered, to get rid of any potential micrometastatic disease or the seeds of cancers that surgeon's eye cannot see or scans cannot pick up. So there are different strategies on how we employ radiation or surgery besides chemotherapy for early stage. And also big factor is what's the primary site of origin. So a cervix small cell carcinoma would be dealt very differently than lung small cell carcinoma in that stage versus pancreatic. So site-specific management teams needs to be looped in. Now, majority of our patients, unfortunately, at time of diagnosis are metastatic. And there, the role of radiation and surgery is extremely limited to none. Radiation we can still employ for palliation. These high-grade neuroendocrine cancers are very radiosensitive tumors. So if somebody has a metastatic lesion which is causing them to have pain or mass effect, then we can certainly do selective radiation to help alleviate those symptoms. But the mainstay of treatment for metastatic disease is systemic therapy. It is a systemic disease. If we do blood tests in metastatic patients, we can find circulating DNA. So the cancer is not in the spots that we are seeing on the scans alone. It is a systemic disease where the cancer or seeds of cancers or the microscopic disease is throughout the body. So we need to engage a treatment that will go throughout the body and try to control it everywhere.
Yeah. Okay. Really good points. And so once you start a treatment, how long does someone stay on the therapy, like say the platinum doublet, FOLFOX, and then can they be repeated later on?
Gotcha. That's a great point, and I've actually seen it sometimes where patients have stayed on platinum doublet longer than I would have preferred. My practice, I usually do 4 to maximum 6 cycles of a platinum doublet. There is a significant risk of bone marrow suppression if you continue it beyond. And there have been times where I've seen patients who came for a second opinion and are like 9th or 10th round of platinum doublet with really poor platelet counts and low white blood cells, etc. So if we are starting with platinum doublet, I usually put breaks at 6, many times at 4, based on individual patient, how well they are tolerating their baseline bone marrow functions, etc. Again, it's a marathon, not a sprint. Even if you continue these highly toxic chemotherapies, the cancer will eventually come back. It's not curative. So my strategy is to give enough chemo to prolong, to get some disease stability, add quality of life, and then whenever the tumor grows back again, then use the next best line of therapies that might include re-challenge with platinum doublet if we have a very good durable response in the first time, or try a second line therapy. For example, FOLFOX. FOLFOX does not really suffer to that extent with the continuation, with cytopenias. FOLFOX suffers with neuropathy issues. So after 5 or 6 cycles of FOLFOX, a lot of the patients will start complaining of neuropathy because of oxaliplatin. Again, so sometimes we have to drop the oxaliplatin or continue 5-FU by itself or use an alternative regimen. So it's really, really important to know that these treatments are palliative for metastatic disease. They're not curative. So we have to pace ourselves. We need to give enough treatment that will help patients live a better, longer life, not at the cost of side effects and toxicities. So this is really, really critical. And we can always try a different treatment, or whenever the tumors stop responding to disease. So there is really no no reason to keep pushing these treatments beyond a certain limit at the cost of side effects.
Okay. And is that how you decide whether to give? You said sometimes you give 4 cycles, sometimes you give 6 cycles. How do you decide who gets the 4 and who gets the 6?
Yes, great question. So most of the patients with high-grade neuroendocrine cancers will respond beautifully to platinum doublet. In fact, the success rate is about, if I give this chemo to 10 patients, almost 7 or 8 will respond. So very, very high chance of response. The issue is the response doesn't last long, and some patient might last for 4 months and some 6 months, very rarely 9 months, but the sweet spot's between 4 and 6 months. That's how much mileage we usually get out of platinum doublet in most patients. So how do I decide? I mean, everybody gets a scan after 2 or 3 cycles of treatment. If I see a very robust shrinkage that allows me to continue to next 2 cycles, after 4 cycles of treatment, many times I don't see further shrinkage. I see stability. So if I have a patient where I'm not seeing further shrinkage, already had some complications with neutropenia or terrible side effects from chemo, feeling very weak and fatigued, or had an hospitalization for some sort of infectious complications, we know that this is not a patient who's doing fantastic. I'm glad that the cancer is stable, but I might refrain from pushing further beyond 4 cycles. On the contrary, if I have a patient who's doing great, tumor continues to show shrinkage even after 4 cycles of treatment, no complications whatsoever, whatever minimal side effects we are seeing with nausea is manageable, and patient is otherwise very fit and active. Cell counts are not low. They're showing good recovery at 3-week mark and ready for next round of treatment. I feel very optimistic in pushing it to 6 cycles. So those are very patient-specific factors that helps me, and then we engage patients in that decision making. Because at the end of the day, it's about quality of life of the patient. If they are meeting the goals of their quality of life, or are we just making them too sick that they are just staying at home all the time and dealing with these complications? That's never my goal.
It's about quality of life. You mentioned side effects a few times and also in the previous slides. Is there anything patients can do to help manage those side effects?
Yes, for sure. So 2 things that I advise or advocate for patients is nutrition and fitness. We know for sure patients who are fitter to begin with have better outcomes. So better outcomes because they, one, tolerate treatments better, and we have more chances of treating subsequent lines of therapies if they are fit to begin with. So optimizing nutrition, not skipping meals. If the appetite is low, talking to your doctor to see what's causing you not to eat. Is it the taste aversion? Is it the smell of foods not making you hungry? Or is it the mass effect that there's a lot of disease in the liver pressing on your stomach, kind of making you feel full? There are different strategies to deal with all of these issues. There's no one size fit all approach. So having a clear conversation with your team that what's bothering you, why aren't you able to eat, and then we use techniques that might help solve the root cause, but at the same time engaging your nutritionist to kind of get you high calorie dense foods. It's sometimes easier to drink your calories, so using smoothies and protein shakes. Sometimes it's very difficult to eat a big platter of food, but you can fool your mind in drinking calories. You take a few sips of a high calorie dense protein shake, and then a couple of sips later, in an hour, you've finished the whole can. So there are ways to kind of get nutrition in your body. The other thing is fitness. Again, fitness, there's no single regimen for all. Whatever you can reasonably push yourself. I don't like patients to spend all their day on a recliner, on a couch. If just walking within the house or walking around the backyard or around the block, any activity is a good activity. So try to kind of be as active as your body would allow you. and that's also really good. Now, besides that, um, you know, discussing with your healthcare provider, the doctor, what to expect if certain chemotherapies are highly emetogenic. That means if you trouble nausea, vomiting, be prepared in advance. So I give them nausea medicine like Composite and Zofran, and on top of that, they'll have some steroids in case. So be prepared, not wait for the last minute, because once the chemo-induced nausea sets in and the patient's already throwing up and having vomiting, it's really difficult to manage with bills, and then we have to get the patient admitted through IV. So it's being proactive. Same thing if certain medicines giving terrible constipation, being proactive, staying ahead, and getting a prescription of bowel regimen so that you're taking enough hydration, enough fiber, so that you don't come up to a point where you're so constipated that you end up in the ER for acute abdominal pain. So just being upfront with the doctor, asking them what to expect, what side effect, when to engage them. Hey doc, don't wait till the last minute. Those are some of the things. And last but not the least, we live in an era of social media. We hear all sort of things about sometimes untested, unproven remedies, and sometimes they can significantly interact with our chemotherapies and exacerbate the side effect profile. I've seen that, and so please always engage your team. Kind of be upfront with them that if you are taking something or you intend to take something, we can certainly review it and run it through at least our databases. Is there known conflict interaction that will make certain side effect more heightened? So if you're taking any herbal supplements or something that is off label, then please discuss it with your doctor first.
Yeah, thank you. Some things that we can all do, in terms of diet, exercise, and then, being prepared. That's a really good point, to be on top of it and proactive and have these discussions. We're going to shift to some questions about small cell lung cancer. There's several questions. The first will be, should non-smokers with small cell lung cancer be tested for mutations? Who should be tested?
So great question. Non-small cell lung cancer, which is the majority of lung cancer, they all get tested for targetable mutations because we have some fantastic game changer drugs when it comes to non-small cell lung cancer. We have not consistently found targetable mutations in small cell lung cancer, unfortunately. So it's not a very universal thing to do in small cell lung cancer. Large cell neuroendocrine cancer is a different entity, and sometimes we do come across targetable mutations in large cell neuroendocrine cancer. So I don't want to treat all high-grade, poorly differentiated neuroendocrine cancer in a similar way. Small cell, lesser chance for us to find targetable mutations as of today. Things change. We find there's a drug that works for a mutation seen in small cell lung cancer. In future, it might change. Currently, the targets that we look for in all solid tumors across the spectrum are NTRK mutations, tumor mutation burden, MSI status. So in small cell lung cancers, the opportunity to find some of these are extremely low. Having said that, I have seen all of these, for example, I've seen MSI high small cell carcinoma of esophagus. So you never say never. In my practice is I try to do target next generation sequencing all solid tumors with metastatic disease. In small cell lung cancer, one of the interesting thing that we are learning is about 1/3 of small cell lung cancer patients do have either intermediate or high tumor mutation burden. Now, it's not of a big significance because patients who do have intermediate or high tumor mutation burden, we have immunotherapy on label, the drug called Keytruda. But in small cell lung cancer, we anyways have immunotherapy, immune checkpoint inhibitor that is per standard of care used as frontline treatment, atezolizumab and durvalumab. So it's not very consequential to no tumor mutation burden because everybody will at some point in time will get immune checkpoint inhibitor in small cell lung cancer. So as of today, actionable mutations are very limited in small cell lung cancer, but there are studies that are coming up which are studying the molecular underpinnings of these small cell lung cancers, and very soon what we will do is small cell lung cancer will not be one standard disease. Like triple negative breast cancer, we will have molecular subtypes of small cell lung cancer. There's already some very high impact publications regarding this, but it's not mainstream yet. So I foresee in future we will do these molecular testing in all small cell lung cancer, and then we will know, okay, this subgroup of small cell lung cancer is going to respond to immunotherapy based drug, or that subgroup will respond to a DNA damaging agent. So we are moving in that direction. It's just not ready for prime time yet.
Yeah. Yeah. And there's a follow-up question that seems similar. So what about a non-smoker patient with a pure small cell lung cancer that has a detected EGFR mutation?
Yes, this is a very unique case. Now I've seen multiple cases where we started the journey with non-small cell lung cancer where EGFR mutation can be often seen, and then down the road the cancer transformed into small cell. So that's not unheard of, it happens. So I wonder if there was an original diagnosis, or non-small cell or adenocarcinoma that either got missed. Small cell lung cancer with EGFR without either mixed, what we call mixed neuroendocrine, non-neuroendocrine carcinoma. So there is a component of adenocarcinoma, component of small cell. It's extremely, extremely rare to find EGFR in just pure small cell lung cancer. Very, very interesting. The data from real world clinical use and what would be the benefit of targeting EGFR in small cell lung cancer is really limited to non-existent. But it will be very tempting to try an EGFR target therapies, at least under a trial protocol. So I would encourage the patient to look into clinical trials targeting EGFR, and might be a good candidate for the targeted therapy. But this is a very unique situation. I wonder if we are missing a mixed neuroendocrine, non-neuroendocrine cancer, or a transformation at some point.
Thank you. There's an interesting question. What drugs penetrate better into the brain with metastatic small cell lung cancer? Are there new drugs available? And I was wondering if you might just discuss a little bit when you're looking for brain mets as well.
Great. High-grade neuroendocrine carcinomas can travel to brain. Low-grade NETs or well-differentiated NETs, the chance of brain metastasis is extremely low. But high-grade neuroendocrine cancers has a decent chance of metastasizing to brain, especially small cell lung cancer, where up to 30% of patients can have brain metastases. So universally, everybody with a small cell lung cancer diagnosis at baseline needs to get a brain MRI to know whether there is disease in the brain to begin with or not. Extrathoracic high-grade neuroendocrine cancer, that means small cell or large cell neuroendocrine carcinoma outside lungs, the rate is not as high as 10%, but somewhere in the range of 10%, still pretty decent number. So always be on the lookout for a potential brain metastases based on the clinical. So if patients come having headaches, blurry vision, weakness, tingling, numbness, one of the extremities, or anything to suspect an upper motor neuron lesion or some sort of brain metastases, I have a very low threshold in getting an MRI brain, especially for these NECs, high-grade neuroendocrine cancer patients. Regarding the question, are there drugs that penetrate better in brain? We have traditionally used temozolomide in brain cancers. So if somebody has a brain cancer like glioblastoma multiforme, so those are brain tumors, not neuroendocrine cancers. One of the preferred drug is temozolomide, and we use that with radiation, and it has a very good CNS penetration. This is also another drug that we use in small cell lung cancer. In fact, one of the NCCN recommended treatment for subsequent line of therapies in small cell lung cancer is temozolomide, and there is clinical data uh, on small cell lung cancer. So I know that this is potentially a good treatment option for patients who uh, have a lot of CNS disease. CNS is always treated preferentially by radiation. That's the mainstay of treatment. But among the systemic therapies, I do like temozolomide, or it is preferred if it makes sense for that particular patient. However, it's not that the other treatments don't work. In fact, these days, if we have very tiny brain met, patients clinically asymptomatic, sometimes we forego radiation for oligometastatic disease, just one or two spot, as very small asymptomatic patient, and we do platinum-based chemotherapy, and we see the subsequent MRI shows the tumor's gone. So clearly there is breach of blood-brain barrier whenever there's brain metastases, and our systemic therapies, other chemotherapies also, they reach to the CNS tissues and they are active. But the data, how active and what are the clear-cut data for different drugs in the CNS are not as robust. So I don't avoid any chemotherapy just because they have brain mets. You know, I still use the similar principle of systemic therapies and try my best treatment first, and then the second line treatment, third line treatment. But yes, brain metastases in general have to keep an eye out on potential of brain metastases, in, especially in neuroendocrine cancers. It is an urgent situation. Patients are at risk of bleeding, strokes, seizures, and need to kind of get an urgent scan, loop in your radiation oncologist or neurosurgeons based on what type of radiation modality we're going to go after, stereotactic surgery or whole brain radiation, and then also have to have a strategy for systemic therapies, chemotherapies, etc.
Thank you. Thank you for that very thorough answer. So what if someone has platinum-resistant small cell lung cancer? What therapy is preferable for second line if lurbinectedin is not available?
Yes, there are a lot of options. Topotecan is our textbook option, which is an FDA-approved drug, second line. I don't like topotecan, so I use the sister drug irinotecan a lot because just the ease of administration and side effect profile, in my experience. However, both these agents are available, and they're, you know, uh, used very often in other cancers as well. So irinotecan or topotecan is one of the agents. Temozolomide, as I mentioned, is also something can be considered. It's a pill form of regimen, so has another advantage of not being bothered by IV infusions and stuff. Um, Docetaxel is also one of the agents. If patients are very fit, I've used CAV, um, but not in the second line. I think we have better options for second line. These are third, fourth, fifth line where we have very limited treatment options. Um, I highly, highly encourage patients to look for clinical trials. There are a lot of really interesting, promising trials, not just in the US, but beyond US. For example, DLL3 BITE is one of those. So I encourage patients to at least look for potential trial options, because I think that's where we will see a potential game changer in near future.
Yeah. Similar question to that is, are there any other options other than chemotherapy for oligomets in the liver in small cell lung cancer? Yeah.
So if it's an oligometastatic disease, we can be tempted to do liver-directed therapy or something of that nature to take care of that lesion, the only lesion visible in the liver. However, I would caution the audience that just because we are seeing a spot in one segment of the liver doesn't mean the cancer is only there. If this is a small cell lung cancer, that means it originated somewhere in the lung and now has traveled to liver. There is concern of micrometastatic disease. That's why you need to be on a systemic therapy. Now, if you use chemotherapy or immunotherapy, that's really based on case by case. So if this particular patient has not had chance to get immunotherapy like atezolizumab or durvalumab in the front line along with the chemo, then the patient can potentially try nivolumab of Keytruda or something in the similar class to kind of control. But I would highly caution the patient, that don't be misled that there's only one spot that we can see on the scan. Oligometastatic disease is on the CT scan or the imaging, but we don't really know if there is more microscopic disease that is too small for any scans to pick. So unless patient in this type of situation, they have gone 2 years or something long duration, then there is no evidence of cancer back. And I've had those cases where patient had an exceptional response to immunotherapy or other therapies where now they only have one spot left. And after a good control of 2 years, we decided to kind of just radiate that spot or resect it and patient's NED. But those are exceptions and not the rules.
Yeah, and could you also define for the audience what oligometastatic means?
Oligo means few. So if somebody has few spots, 1, 2, or 3, then that's what it implies. In small cell lung cancer, again, because it's an aggressive cancer, there's a very high chance of a lot of other disease or microscopic disease that we are just not able to catch on the scans. Oligometastatic disease is less of a consequence, or it doesn't change the management approach. Once you have a metastatic disease, whether it's oligo or widely metastatic disease for small cell lung cancer, I treat them very similar. This is different for well-differentiated neuroendocrine tumor, because there, even if you have metastatic disease based on you're dealing with low bulk disease, that means oligometastatic, just 1 or 2 or 3 spots, versus a lot of disease, multiple organs, there might be a big change in how we manage those cases. For oligometastatic disease, I might recommend surgical debulking rather than trying PRRT. But in small cell lung cancer, even if you have 1 or 2 spots and it's a metastatic spot, it's a metastatic disease. And unfortunately, we have to treat it with systemic therapy. Just by treating that one spot, it's very low chance that we will get long-term benefit.
Thank you. This is an interesting question. This person was on atezolizumab in second line for large cell NEC for almost 2 years and now has mets in the cervical lymph node. The last part of the question is interesting. Can radiotherapy renew effects of immunotherapy? So that question about renewing a treatment, is that possible?
Yes, this is an active area of research. I'm glad the patient here had a really good response. 2 years on atezolizumab, which is a very well-tolerated immunotherapy drug, and high-grade neuroendocrine cancer with such a robust response is always good to see. We are still trying to understand why these treatments eventually stop working in some patients. The mechanism of resistance we are trying to understand. One of the mechanisms of resistance could be immune fatigue, that these are immunotherapy drugs. These are really not cytotoxic drugs. These are not killing cancer by themselves. This drug atezolizumab is really making your own immune system fight against the cancer. So is it possible that the immune system is fatigued out after 2 years? It's a possibility. That's one line of thought. And the other could be that the cancer genuinely has developed other pathways of resistance that they are now growing, which doesn't respond to immune checkpoint inhibitor. In these kind of situations, what I do is give a break from this treatment, because clearly atezolizumab right now is not working. There's relapse. I employ next line of therapy. You can do radiation for focal disease if it hasn't spread widely, but at the same time, either before or after radiation, I will usually employ other systemic therapies, in this case, probably a chemotherapy. And after a while, when the chemo either stops working or, you know, we had good disease stability, at some point in the future, reintroduce immunotherapy. When I have personally seen cases where patients who had great response to immunotherapy, but they eventually stopped working. If I had some cooling off period and I was able to stabilize the disease with something else, like a chemotherapy or a completely different class of drug, I was able to see that these immunotherapy drugs were resensitized again. At least in those patients, probably it was immune fatigue, and then after several months of break from immunotherapy, they were working again. In large cell neuroendocrine cancer, especially outside lung, I also often use ipi-nivo. So there are two immunotherapy drugs instead of single agent atezolizumab. So they're both immune checkpoint inhibitor, but they have subtle differences. One is a CTLA4 and the other a PD-1. So many times if I'm in this kind of situation where patient has progressed on atezolizumab, and in future, if I have opportunity to re-challenge with immunotherapy, I might go with ipi-nivo. And there is some data in high-grade neuroendocrine cancer that ipi-nivo is a pretty good option.
Thank you. Similar question, at what time of the small cell lung cancer progression can immunotherapy be continued? And at what time of progression should immediately switch to another line?
Yes. So if there's clear progression on immunotherapy, multiple organs, and then I've often just stopped immunotherapy and switched to the next line right away. There's no time to lose because these cancers otherwise will continue to grow. There have been some exceptional cases where immunotherapy maintenance was working phenomenally well, controlling the disease in liver mets and adrenal mets and lung. The only site of progression was, let's suppose, brain. In those cases, I have, of course, brain mets needs to be treated appropriately with radiation. I have incorporated newer line of therapy, be it temozolomide or some other chemotherapy, and also continued immunotherapy because it had worked really well to control the disease outside the CNS. But those are very case-specific discussions based on availability. Some insurance agents and insurance won't allow you to continue a therapy or allow you to combine with something else. So those are very difficult to answer in this sort of forum. But anytime there's clear progression, usually the right answer is switch the therapy, because if you keep doing the same thing, you will not see the different result.
Okay. And there's this question, can Trodelvy be used to treat small cell lung cancer or large cell neuroendocrine carcinoma? And could you define what that drug is?
So Trodelvy is a breast cancer drug. It's actually it's a TROP2 drug, and can be also used in other tumors with targeting of TROP2. I'm not very familiar with the drug, to be honest, because it's not very commonly used in our area in neuroendocrine cancers. I have had few patients who had high-grade neuroendocrine cancer of breast, especially triple-negative breast cancers, where this drug was used, or they were previously treated on it, or they're being considered to be treated on it. So outside breast, I don't have a lot of experience with it. Definitely not a mainstream drug for small cell lung cancer. Specific case-based nuances will have to be made if we are dealing with a small cell carcinoma or large cell neuroendocrine carcinoma of breast that either has transformed or is a mixed, what we call minin, mixed neuroendocrine, non-neuroendocrine, where you have a traditional breast adenocarcinoma along with a small cell. So for those rare situations, I can see why we might be using Trodelvy, but this is not a very specific drug for small cell lung cancer.
Okay, thank you. We're going to shift to some areas of research. Is anyone looking at germline whole genome sequencing data for hereditary causes of high-grade neuroendocrine carcinoma, especially for very young adults?
It's a great question. I think there are some studies, but the numbers are very small. one of my good friends, Dr. Sukritan from Ohio State, had a study, an abstract where they studied the germline data, but in all neuroendocrine cancers, uh, of course, most of their subset was a well-differentiated neuroendocrine tumor, but they did had some, at least the abstract I reviewed, about 10% patients in their group were high-grade neuroendocrine cancers. But I think this is a great question. I think we need to definitely consider doing larger multi-center studies, and also the current studies, because germline mutation can be impacted by ethnicity and the region that you are in. So I would be very interested to look into Florida or Hispanic populations, and similarly, is the high-grade neuroendocrine cancer population in Europe or Asia, do they have the same degree of presence or absence of germline mutations? I think we need to do better studies, and more data needs to be gathered in this regard. So it's a great question.
Yeah. Let's talk a little bit about the BITE trial, the one that you mentioned you're excited about. What are the inclusion and exclusion criteria, and what's the wait time? This is actually a combination of a couple questions, and there was a separate question about, is stage 4 atypical carcinoid of the lung also a candidate?
Great. Well, it's difficult to answer this question because the inclusion exclusion criteria would be very specific to different trials. There are various BITE trials, either active or in stages of activation, which will be catering different patient populations: small cell lung cancer only, or all neuroendocrine cancers, or some neuroendocrine cancers and excluding prostate neuroendocrine cancer or Merkel cell neuroendocrine cancers, etc. So we'll have to really look into site-specific trial. So I would encourage you to first do a broad search on clinicaltrials.gov regarding what BITE DLL3 studies are available, accessible in your region, and then look into it. The study, I've actually been investigating a couple of different BITE agents, so I've had a little flavor of everything. The most recent one that University of Miami's partnered with and are conducting the studies, Darien-5 study, that is very inclusive of all high-grade neuroendocrine carcinomas, but they have to be poorly differentiated neuroendocrine carcinomas, or they can be mixed, but majority of tumor has to be poorly differentiated neuroendocrine carcinoma. So atypical carcinoid might not qualify unless we do a thorough path review, and then we gotta make sure that that if there is high grade neuroendocrine carcinoma component, then maybe consider. But the fact that it's atypical carcinoid and not large cell neuroendocrine carcinoma, my understanding is that at least in the Darien-5, that would be an exclusion. So yeah.
Thank you. I'd like to get to this question. Is there a drug to target the TP53 mutation?
It will be extremely exciting if we can find a great drug that targets TP53. This is one of the commonest mutations in high-grade neuroendocrine cancers, and not just high-grade neuroendocrine cancer, but all solid tumors in general. So far, and there are drugs in the pipeline, but I've yet to see something really fantastic, promising. But the scientific community is trying, because this is very, very common pathway, that is affected in a lot of cancers. So that will be fantastic if we can one day find a great drug to target it.
Thank you. I'll just take a couple more questions. You mentioned that it's important not to delay the treatment with high grade, and that the doubling time is really fast. So if someone has a new diagnosis of high grade neuroendocrine cancer and they want to see an expert, where does seeing an expert fit into all of this?
My personal philosophy is get started with the treatment, and then see the specialist, because in my experience, again, it's not one size fit all approach, but there is more to lose by delaying treatment. than getting an expert opinion in right up front. Because if it is truly high-grade neuroendocrine carcinoma, the NEC, and if it's metastatic, this treatment of choice, the platinum doublet or something similar like Folfox in GI, is very universal, and it's you know so there's not a whole lot of difference. Where it becomes challenging is second line and onwards. So having an expert on board or a specialist on board can help you kind of sequence what to do, accessibility of clinical trials and things like that. But the upfront management is pretty much same. So if I have a small cell lung cancer patient here or in India or Germany, they'll almost always get the same type of treatment. So I think it's important to get an expert in, but not at the expense of delaying the treatment. Now, why I leave certain caveats in is because, are we truly dealing with high-grade neuroendocrine cancer? Is this a misdiagnosis? Are we dealing with a well-differentiated grade 3 NET and not NEC? And that's where it becomes challenging. But if it's a very slam dunk diagnosis, a small cell or a large cell, I think there is you can comfortably proceed with systemic therapy with your local oncologist, and also make them rush, because sometimes they also don't understand the aggressiveness of the disease. So you have to advocate for yourself and try to not get delayed. Oh, we have a PET scan schedule in 3 weeks, and then we will see you, and then we will start the chemo in 5 weeks. That kind of approach is not ideal for high-grade neuroendocrine cancers.
Thank you. Thanks for helping clarify this. And we'll end with this last question. What are you most hopeful for in this area of high-grade neuroendocrine carcinoma and small cell lung cancer?
So I'm hopeful that, at least within my career, that's my hope, that we will find major breakthrough in how we manage small cell lung cancer and high-grade neuroendocrine cancer. This is truly an unmet need. The 5-year survivals are not anywhere close to where we want them to be. We have made huge strides in breast cancer, lung cancer, colon cancer. We would like to see something similar for small cell lung cancer and high-grade neuroendocrine cancer. It's not for the lack of trying. There are a lot of drugs that have been tried in last decade. It's just a very challenging disease. But the next generation of studies be novel immunotherapies, like BiTE DLL3, and there are others hopefully in the pipeline with the combinations, oncolytic viruses, in checkpoint combinations. I do see a ray of hope that we might find a major breakthrough. We all have patients in our practice with small cell and large cell neuroendocrine cancer who are disease free 2 years, 4 years, and those cases gives us motivation that if a certain drug worked in this patient, we can try to replicate in larger patient population and keep working hard in finding new pathways, new targets. So clinical trials is where it's at. We need to do more trials. We need to encourage patients to participate in these small cell or high-grade neuroendocrine cancer specific trials, because that's where the breakthrough and hopefully cure one day will come from.
Thank you so much. Thanks for your time. Thank you for your passion for high grade, this area that certainly needs more attention and more treatment options. We really appreciate you for dedicating your career to this area and for the compassionate care you give and all your work to bring about promising research for future treatments. You give us hope, and those rays of hope, we'll take it. Hope is everything. So thank you again for all you do, and we look forward to talking again soon. I'm going to now send it to...
Yeah, I just wanted to give a shout out to LACNETS for advocating for our high-grade neuroendocrine cancer patients. Very limited resources are available for NECs, and I appreciate wholeheartedly to your team for kind of focusing on this rare cancer and making these resources available to our patients. So thank you so much.
Well, together, hopefully we'll work towards a cure. Definitely more rays of hope for everyone. So I'm now going to send it back to Heather in the studio.
Thank you again, Dr. Chauhan, for your important presentation and for your informative answers to so many questions from this audience. We appreciate our supporters, Ipsen, Crinetics, and Curium. Educational programs like today's are also made possible by donors like you. Please consider making a donation today at lacnets.org/donate. And a special thank you to our technical director, Rich Tamayo from TVP Live for this high-quality broadcast production. Today's presentation and Q&A session have been recorded and can be viewed on our website and video library shortly after this broadcast. If you register for today's webinar, you may receive a survey via email. We would greatly appreciate you completing this survey as it helps us with event and fundraising planning. Again, follow us on social media to stay up to date on our upcoming educational events. Our handle is @LACNETS. And now back over to Lisa.
Thank you, Heather. LACNETS is a community of support and resources, and we recognize that you are more than your disease. So we aim to support you as a whole person. To this end, we offer many resources and programs. Find out more on our website, lacnets.org. LACNETS has a monthly podcast featuring experts who answer the top 10 questions in their field. Go to our LACNETS podcast page to check out the episode transcript, resources, and the 10 questions we asked the expert. And remember to register for our 2024 Neuroendocrine Tumor Patient Conference next month on Saturday, June 15th. You won't want to miss this. It's an amazing opportunity to hear from experts across North America and also several NET patients and caregivers. Register now on our website, lacnets.org/2024 conference. Thanks again for joining us for today's educational event. We look forward to seeing you next month for our 2024 Neuroendocrine Tumor Patient Conference. Bye.